preparing to live stream.
Hello and
live stream.
Thank you. Hello and welcome to the Health and Government Operations Subcommittee on Public Health and Minority Health Disparities. This is our first meeting of the session, and today we're going to be having a briefing on the impact of violence on healthcare in Maryland. We have some new members on our committee and some returning members. I guess to save time, we won't go ahead and do introductions, but everybody can see the members who are here. I'll just make sure to read them off. We have Delegate Alston, Delegate Bagnall, Delegate Chisholm, Delegate Hill, Delegate Hutchinson, Delegate Lewis, Delegate Lopez, Delegate Riley, Delegate Rosenberg, and Delegate White. So together we are going to be doing the work of the Public Health and Minority Health Disparities Subcommittee this session, and we're really looking forward to it. So with that, we're going to hear from, I believe that the order, and tell me if I'm wrong, is Martha Nathanson is going first. Is that right, Martha? Perfect. Okay, so let's go ahead right on in on our briefing on impact of violence on healthcare in Maryland. And committee members should have received the PowerPoint slides in their inbox if you need copies of them. Go ahead. Welcome, Martha. Thanks for being here.
Great. Thank you. So great to see you again. I'm really excited that we're the first briefing for this great committee. So thank you so much for your time. It's great to see everybody. I'm Martha Nathanson, Vice President of Government Relations and Community Development for LifeBridge Health. We are a system serving Central Maryland and Northwest and West part of Baltimore City and County. We have Sinai Hospital right next to the Pimlico Racecourse and Levendale Long-Term Care Center, and shout out to Delegate Rosenberg for representing us there. Northwest Hospital in the beautiful 10th District. Welcome and shout out to Delegate Jennifer White. We're so thrilled to have you with us. Carroll Hospital in Carroll County and the former Bon Secours Hospital, now Grace Medical Center, which we acquired a couple of years ago in West Baltimore. Our goal for today, we know you know this connection between violence and the impact on healthcare. We want to deepen your understanding if we can, and at least lay out some resources that you can have to serve as a filter or a lens that as you debate future healthcare policy and issues in your subcommittee and your committee, that's another lens you can put over this, the impact of violence on our communities and the connection between health outcomes, which we all want to see improved, and violence that is rampant in our communities. I know you're hearing about violence from all angles in your communities, and this is just the connection to healthcare. It's not really new for you. Delegate Lewis has paved this way with trauma-informed care. That's now serving as a basis for all of these discussions. So thank you for all of that work there, and Delegate Riley for serving on the commission that resulted from that bill a number of years ago. So you're steeped in this as well. The committee last year passed a wonderful bill allowing for Medicaid coverage for community violence intervention services. You'll hear more about that with the other panelists, so I won't go into that. And I'm going to mention workplace violence, though this briefing's not about that. You'll hear a lot about that in the connection with the work that you'll be doing on healthcare workforce issues. And a shout out to Delegate Bagnall for passing that bill last year, and a program that's about to get started to highlight the impact of workplace violence. Look, the violence in our communities comes into our facilities. It doesn't stop at our doors. So highlighting that is going to be critical. So thank you for that, Delegate Bagnall. I'll go on to just make two major points. In looking at the connection between, people always ask me, why is the health system investing so much in violence? Yeah, we get your cancer services and your heart screenings, and how did you get started in this, and why is this such a focus for you? There's a sort of easy, direct way to look at this, and then something else that I'll share with you in terms of the feedback that we got from our communities on this. The direct way, although not easy to deal with, very difficult to get your arms around, is we're a level 2 trauma center at Sinai Hospital. We get gunshot wounds. I'll just use that as an example. Any kinds of criminal acts will end up, and injuries will end up in our trauma center. But the gunshot wounds, the cost of those, some can be $80,000 to $100,000 for a 9 to 10 day stay. We have one case that was $650,000 for a 97-day stay for a gunshot wound. So the cost is one way to look at that, but the trauma that the patient and their families and their communities that ensues from these is one of the indirect costs that we want to make that connection for you. One case
Martha, can I interrupt you for a second? Did
Sure.
you want us to have your PowerPoint slides up during this? Did you?
Probably. Mine's just a background slide, but yes, the other folks will be using theirs more
Okay,
actively.
so when we get up to Taria, we'll start the slides.
Yeah, that's fine.
Great.
Mine was just a background.
Well, your background slide is, breaks down. I was noticing the violence
question.
slide. So I wanted to make sure. Okay, thank you.
No problem. Thanks for checking. I sort of forget about that kind of stuff. One case, I know you probably all heard about the mass shooting midday in Park Heights about 2 months ago, maybe 3 months ago. Noon, 7 people were injured, came to our trauma center. One gentleman came in, stayed for about 10 days, left. The cost of that at that point was about $100,000. He came back 3.5 months later with another gunshot wound. Unfortunately, he did not survive that, but a few hours in our trauma center. So the cost is difficult to quantify, easy to quantify dollar-wise, difficult to quantify in other ways. And then the other way that I answer the question, how did you get involved in this type of work? As a hospital, our CHNA, you know that word, the Community Health Needs Assessments that we do as part of the Affordable Care Act. In 2015, way back in the day, that's what we heard. We heard heart disease, we heard cancer, we heard violence in jobs, right at the top of the list of concerns that people had about their health was violence. So back in 2015, and you'll hear more about this again, so I'm not going to go into it, we started a small program to connect victims of violence in our trauma center, in our ICUs, in our medical units after they were medically stabilized. We often heard that the only thing keeping me from going back into the street in this way is a job. So we have a training program at Sinai that's been around for about 50 years. It's called VSP. It's a training center, and we offered victims of trauma and of violence access to training for potential jobs. We love when they come to work at LifeBridge. It's not a condition of that training. The healthcare workforce is the healthcare workforce, but getting people into that workforce, we're the largest employers in our communities. We can help provide jobs. And the CHNA, our feedback in our community health needs assessment was violence is a top concern for us. So we've blossomed at LifeBridge Health from 4 or 5 workers back in 2015 to over 100 people addressing various aspects of violence. And Freedom Jones will close out our panel with a discussion of this. So I'm going to turn it over to our first two presenters in the interest of time. Well, the first is a member representing the coalition working on gun violence in Maryland. The second is the Health Alliance for Violence Intervention. You'll get more of a national picture of what's going on and how Maryland fits into that, and a smattering of all the resources that are available, both financial and other, to deal with violence and healthcare outcomes as you debate future issues. So I will turn it over to Taria. Thank you so much. See you all soon.
Thank you, Martha. And hi, everyone. My name is Taria Stanley, and I am the Regional Advocacy Associate with Community Justice. Today, I am here on behalf of Marylanders to Prevent Gun Violence Coalition as co-chair. We are a coalition of multiple Maryland-based organizations that come together to advocate for gun violence prevention and community violence intervention. I got into this work because I've seen how gun violence has affected my community back at home in Dayton, Ohio, and my family personally. And unfortunately, I know many Maryland residents can say the same. So we can go ahead to the next slide just to dive deeper into the public health crisis of gun violence. We've seen historic spikes since 2019, a 35% homicide increase, a 39% Black homicide increase, and a 172% teen homicide increase. This leading to gun violence being the #1 cause of premature death for all youth and Black men. We also know that gun violence affects Black and Latinx communities at disproportionate rates. We can dive into the annual cost of gun violence in the next slide. So I'll just touch on this briefly. The cost per homicide is about $1 to $2 million. For example, I know in DC, the cost is about $1.5 million. For Maryland, the annual cost of gun violence is $5.7 billion. And nationally, it is a $557 billion cost for gun violence. Just to give a little bit of the cost breakdown and what goes into that, we have hospital and rehabilitation, victim and family support, and crime scene response, just to name a few. We can go off to the next slide. We will be diving a little deeper into the cost of gun violence in Maryland, what you need to know and what you need to know about about gun violence in Maryland. So in an average year, about 724 people die from guns in Maryland. An additional of 1,747 people are wounded by guns. We know that guns are the leading cause of death of youth in Maryland, and an average of 58 children and teens die by guns every year. Again, the cost of violence in Maryland is $5.7 billion, and taxpayers are covering about $375.8 million of that cost. Next slide, please. When discussing the public health crisis of gun violence, this is how we are seeing gun violence affect our healthcare system. And I know we'll be diving a little deeper into this later on. But the University of Maryland has calculated that 5,557 Medicaid enrollees are treated in hospitals for violent injuries each year. According to the American Association of Medical Colleges, emergency department care for firearm-related injuries cost an estimated $1,500 per patient. Inpatient care for firearm-related injuries can cost approximately $31,000. Again, that's just a ballpark area of the cost of those things. Next slide, please. So when it comes to addressing gun violence as a public health crisis, this is what we are seeing on a federal level. We know there has been a $250 million investment over 5 years with the Bipartisan Safer Communities Act. We also know the administration has opened 26 federal grant programs. And when it comes to state and city investments, we've seen states like New York invest $36 million into gun violence prevention and community violence intervention. We've also seen California invest $200 million in community violence intervention. Next slide, please. CVI strategies target those most at risk. 60% of gun violence can be predicted through a social network analysis. 40% of those shot are killed or injured again within 5 years, repeating the cycle of gun violence. Less than 2% are connected to 80% of community violence. And we know this population is the hardest to reach without targeted strategies. And when we are discussing CVI, we are focusing on common evidence-based violence prevention models, such as violence intervention. This is community and hospital programs focused on directly intervening interpersonal or group conflict, negotiating ceasefires, and shifting neighborhood cultural norms. We're speaking about survivor support services, programs focused on providing social services for survivors of gun violence. This includes resources like housing, employment, trauma therapy, etc. And then we are also talking about cognitive behavior therapy. These are programs focused on changing the mindset, mental health, and ultimately the lifestyle of those most at risk of gun violence. We know investing in CVI strategies work. For instance, when discussing New York and their investment in CVI strategies, there was a 35% reduction in gun injuries in the Bronx and a 50% reduction in gun injuries in Brooklyn. These are just a few examples, but these examples prove the effectiveness of investing in CVI strategies. And this is why we have come together as a coalition to advocate for the $40 million VIP bill funding, so the state of Maryland can continue the life-saving work of addressing gun violence as a public health issue in a public health crisis. So that's all I have for now on my end, and I can go ahead and turn it over to Kyle to continue the discussion.
Madam Chair, if I could just jump in, I forgot to mention that we as a panel thought that we would present and people could ask questions, members could ask questions afterwards, but obviously if there's any questions in between, that's fine, but that's why we're flying a little bit.
And I appreciate it, and okay. I agree, as a general rule, I agree with that. Unfortunately, since I'm hopping off at 11:25, I just have a clarifying question that I think will be important for the committee for Taria. So if we can go back to, I think it's slide 7, the slide before President Biden, the public health approach to gun violence slide. I'll just ask a clarifying question, and then I'll ask all the other members to put a pin in their question so we can have a robust discussion that sadly I won't be here for, but I'll watch the tape because I'm very interested in this. The part that says, according to AAMC, ED care for firearm related injuries costs an estimated $1,500 per patient. I don't understand that number. Do they mean $1,500 per patient looking at the universe of patients in the ED? Is that what that means?
Yes, yes, that's just like, yes.
So of anyone who goes into the emergency room, $1,500 basically off the top of ED costs is because of treatment for firearm related injuries.
Yes.
as opposed to the next statistic is 31,000 for inpatient care for people, for individuals with firearm injuries.
Yes, correct.
Perfect. Thank you for that clarification. I appreciate that. And now we can move.
And I can also provide you some numbers on those. Ours, as a trauma center, they might be generally higher. We can differentiate between the ED and the trauma center for you at some point if you're interested.
Because the trauma center, because the numbers you were citing that were closer to 1 million, these are really, yeah, got it. Thank you. And thank you for this presentation. It's been really wonderful so far. And let's move on to Kyle Fisher was next, right?
Hi, everyone. Thank you so much. Just while they're pulling up my slides, I can introduce myself. I'm Kyle Fisher. I've met a lot of you in the past, and it's great to see some of you again, and some of you are new. This is wonderful. I'm an emergency doc out of the University of Maryland. I've got a couple of hats today, actually. I was one of the founders of the Capital Region Violence Intervention Program out of Prince George's Hospital. Now the hospital runs it since I'm up in Baltimore. And I am the policy director for the Health Alliance for Violence Intervention. The HAVI is the national organization that represents hospital-based violence intervention programs. There's about 50 member programs that we have around the country, and about that many that are starting up new. So my goal for right now is, you've just heard from Martha and Taria about the public health approach towards violence intervention, and you're sitting there thinking, we're on the health committee, but what exactly practically does that look like? And so I'm going to tell you a little bit about hospital-based violence intervention programs and what that looks like in practice. So next slide. These programs have been around for about 25 years. On the left side of the screen, you see a young man by the name of Sherman Spears. And in like 1994, Sherman sadly got shot in Oakland, California. And as he was lying in his hospital bed in Highland Hospital, he noticed that the doctors and nurses were doing their duty and changing his wounds and making sure that medically everything was good. But so much more was happening in his life at that moment that he noticed was not being addressed. On the one hand, he was having the trauma and traumatic stress and what happens next. On the other hand, friends and family members were kind of winking and saying, what do you want us to do about this? And the rest of the system was not addressing that. It was just treat your wounds, discharge you. And Sherman realized that that was not a good system. And so he actually ended up partnering with one of the nurses in the hospital to create one of the first hospital-based violence intervention programs in the country. And around the same time, actually, here in Maryland at the Shock Trauma Center, we were starting a similar program at the exact same time because we were realizing the same thing that Sherman was realizing. So back in 2009, that was when a network of hospital-based violence intervention programs started, with Shock Trauma being one of the founding members. And like I mentioned before, we have about 50 programs nationwide now. Next slide. So what does that look like? What that looks like is this idea of treat and release for gunshot wounds is a failed paradigm. It doesn't work. And so we have kind of a 4-step approach towards this to keep it very simple. So what it looks like is, in the hospital, there's this golden moment of opportunity to intervene and change the life course of patients that have been injured. We provide trauma-informed care. We, in that moment, it's a hot moment, right? So we have violence prevention professionals, who I'm going to talk about a little later, that intervene and see, okay, is there anything we need to do right now in case there is any risk of retaliation or a hot situation, and work on that. In the hospital, we identify a comprehensive care plan that the patients will need to fully recover, both physically, psychologically, and socially. That is something that we are going to plan to work on in the next 6 months or a year. And then we make sure that we get these patients all of these follow-up services so that they don't fall off the radar, right? All of these patients are generally disconnected from institutions and the traditional healthcare system, and our violence prevention professionals help walk them through this, their recovery, and address the social determinants of health. And this includes everything you might imagine that could possibly be a barrier to someone's recovery. So it goes everything from making sure people have health insurance, making sure that people get connected to victims of crime compensation, housing, safety planning, education. Do people need a job? Do they need to get back to school? Mental health. Post-traumatic stress is a huge issue. The human brain does not recognize a difference in getting shot in Afghanistan and getting shot in Prince George's County or Baltimore or anywhere else in the state. The brain doesn't recognize the difference. If counseling, substance abuse, you name it, if the patient needs it, it's part of the recovery plan. So you might be asking yourself, what happens if you don't do that in the old system of treat and release? Well, the numbers are quite stark. And it turns out, on the next slide, please. If you do nothing, we have 19 clinical trials. I don't know why we keep doing them, but roughly 1 out of 3 people will be shot again and will come back to the hospital or die, like Martha mentioned. We have trials as high as 62%, so the lowest is 8%. Think about that. This is young and healthy people that don't have diabetes or heart disease, otherwise healthy 20, 25-year-old people with life-threatening injuries that they can experience again. Next slide. Luckily, we have good data on how well this works. These are 3 randomized controlled trials that have been done on hospital-based violence intervention programs. The one on the far left, Dr. Cooper, who some of you may remember, who he was a trauma surgeon at Shock Trauma, and then he was the CMO at Prince George's Hospital for many years. In his trial, he found that in the patients that did not get hospital-based violence intervention program services, 36% were re-injured, but in people that did take part, down to 5%. So that's a really good, in medicine, that's about as good as it gets. That's better than aspirin for heart attacks, to be honest. The trial in the middle is Chicago, going from 20% to 8%. And then on the right is from Virginia. And some issues with follow up on that, but I'm a good academic and we insert everything in it. So next slide. There have been subsequent evaluations as well. Institutional review boards don't believe it's ethical anymore to do randomized control trials, so we don't do that. And what we find is that compared to what happened before, most HFIPs have re-injury rates around 4 or 5%, which at the bottom slide, that's just kind of the review that I just showed from a couple of slides ago. And if you recall, the best, if you did nothing on that review, was 8%, even though most were 25 or 30%. And you can see that in these other 3 reviews, we did much better. So next slide. The reason for this really is the role of these frontline workers, the violence prevention professionals. These folks, you can kind of think of them similarly to community health workers. They are people from the communities that serve that look like the patients, they talk like the patients, they know the people, they know the culture, and frequently they have been injured themselves. When we started CapVit, the first hire that we had was young man named Che that had been a patient at Prince George's Hospital with many stab wounds years ago and had recovered enough that he was looking to help out other people in a situation similar to him. Next slide. And I think it's really worth just pointing out very straightforward and very bluntly that one of the most important things that they do is our patients are cut off from the mental health system. There aren't many psychologists and psychiatrists. There is so much more need than there is. And these frontline workers help get that treatment that is otherwise unavailable. The post-traumatic stress of people with gunshot wounds is tremendous. It's about 80% of patients that have been violently injured will have signs and symptoms of post-traumatic stress. And our violence prevention professionals do a great job at helping get those mental health services to people that otherwise are disconnected to services. Next slide. And of course, this is about more than just not getting shot, right? Getting shot, avoiding re-injury is about the lowest bar that you can imagine for success of a program. So we measure a lot of other things as well, things that patients think are important. So in a couple of different trials that we've noticed that mental health needs are what patients report as a need, and we meet those 70 to 90% of patients. Family counseling, education, employment, substance use, legal court advocacy, childcare, parental supports. We're addressing all of those and being successful at pretty high rates. So last slide. And we always got to talk about money, right? Because This is an investment for a team-based approach towards violence prevention. How much does it cost versus how much does it save? I like to provide local dollars and local data whenever possible. So this is that shock trauma randomized control trial again. And in that control trial of about 100 patients, 56 in the HFIP group, 44 in the non-intervention group. You can see in those highlighted slides for just looking at two things, cost of hospitalization and cost of future criminal justice system involvement, being incarcerated. People that were in the program, we decreased that spending from $1.7 million to $450,000 on the incarceration costs, and on the hospitalization costs, $736,000 to $138,000. So we've got good cost-effective data as well. So let me pause there. On the last slide is my email address, so I can answer any questions afterwards. And thank you so much.
I don't know if I should jump in. Am I next? Well, hello, everyone. I am Freedom Jones. I am the Director of the Community Violence Intervention Programs for the Center for Hope. And, you know, I don't know if you know about the Center for Hope, but the Center for Hope is, for me, an ideal institution that really provides supports around all kinds of trauma entry points. So there are programs, as the slide says, for child abuse, domestic violence, human trafficking, et cetera, et cetera. Any entry point that really deals with trauma. I get the privilege of really managing two of the hospital responder programs, our hospital responder program at Grace, our hospital responder program at Sinai, and all of the Safe Street sites, the 6 new Safe Street sites that we have now brought on board the Center for Hope LifeBridge consortium of violence interventions that are happening in the street. I also have a program that's called PAVE, Pathways to Advocacy Against Violence Every Day. You can take this slide down because I'd rather look at everyone's face, because I want to share with you a little bit about what this looks like from a public health practical experience. And so you know this model, all of our programs are really operating from a public health theory. And in theory, we all know, you know, that a disease will spread unless you have a strategy, a cure, or a methodology for this disease. And so there is a methodology for the way we do this work. So like I said, I want to start out by painting a picture. We you know, you hear the term ecosystem across the country. There's this trend about an ecosystem, and you know, the mayor's office, they're really kind of breaking the ground to help folks understand that violence is a pretty complicated issue, as we all know. It's not just one particular entry point. It's not just domestic violence. It's not just gunshot. It's a layered situation, and we're looking at having an ecosystem being a consortium of partners helping to prevent an ongoing reoccurrence of violence from all types of areas. And so we at the Center for Hope, and like I said, I am really extremely thrilled to be able to have, under the programs that I support, a mini ecosystem. So let me give you a scenario. And most of this is true, but you know, I've tweaked it just a bit. So here we have almost 58 guys who are mitigating violence on the street. We have teams in the hospital who are meeting at bedside. When I say they're meeting at bedside, you know, I have gone to the hospital after someone has been shot. Because I had to administer first aid. I was a director of a Safe Street site when I came here. And I myself had to go in the street and administer first aid to a young man who had been shot twice. The young man ended up at the hospital. He met a hospital responder person at the hospital, but I wanted to visit him. And so I visited him. And during that visit, I realized that through my conversation, this young man wanted to change his life. That opportunity at bedside was an opportunity to help someone move in a different direction, to make some different decisions, but getting the support to do so. So imagine this. Here's the situation. There was a young woman who was a high-ranking person in a particular gang. We were looking, I was actually looking, not here in Baltimore, but I was in New York. I was actually looking for a site to be able to find a building to house a Safe Streets building. There was a young man who was about 6 feet in front of me. During that time, this young man got shot in the head and in the chest and was killed. Because of the Safe Streets model, you have a shooting response, you rally together, you give information to the community to provide supports. There was other people that were shot during that particular incident that were taken to the hospital. So now you have hospital responders meeting those folks at bedside to mitigate any family members that are coming in that are angry, because statistics have shown us within 72 hours of every shooting, there is the highest likelihood for retaliation. So you have a team of people at bedside meeting people to mitigate any high energy. The doctors are providing the treatment. The responders are providing the mitigation of ongoing violence and helping to help the family move through a really horrible issue. So the young lady actually who was we do a shooting response. Safe Streets does a shooting response every time there's a shooting. They go to the location because we know through a public health model that when there's a lot of violence in a particular area, it becomes a normal situation. So in essence, if you're looking at violence as a disease, you want to stop the spread of the disease by helping the community understand that this is not normal. This disease of violence is not a normal part of our everyday living. And so you're flyering, you're giving out information within that 72-hour time frame to prevent an additional shooting. So this young lady called me. She got my card. I happened to be the only woman who was doing this work back in the day, and she took my card. She called me up and said, "What can you do for me?" Okay. She, like I said, was a high-ranking member of a gang. She could have killed anyone or put that out in the community to kill more people. Because of the work that we did as a team to go to her house, bring in the clergy, coordinate the effort at the hospital to make sure anyone else who was connected to that shooting had the supports needed. We worked with this young lady for weeks. This young lady wanted to kill someone, but she didn't. She then became an advocate for the people at the hospital. She then became an advocate for the people who could have killed. Don't do it. These people don't do it because they know they're here to support us. So she did not encourage more violence. She then became a spokesperson for the Safe Streets component and became, after some time, supports a coordinated effort. She then became a violence interrupter. During that particular year, because of her clout and the ability to mitigate violence statistically in that particular area, violence went down 75% because of her clout. So then, how did she get from not killing someone with that ability to becoming a staff person? How did she get there? Well, we had a coordinated effort. One of the things that I'm extremely proud of at the Center for Hope is that we have a coordinated effort. This is about a mini ecosystem. We have folks at the hospital. Our hospital responder program is a comprehensive program. We have responders for gunshot victims, credible messengers who've been there, done that, who are meeting at bedside. We have responders for domestic violence. We have responders for human trafficking. We have responders for elder abuse. So all these people are credible messengers meeting at bedside. So meeting at bedside just doesn't mean that incident. It means that you can become a part of a caseload. You can then become someone who we're wrapping ourselves around to give you the resources and the support to change or make better decisions or in your life. So in that coordinated effort at the Center for Hope, we can then provide through our PAVE program, Pathways to Advocacy Against Violence Every Day. Well, we all know trauma. I am so grateful for the work that has been done around trauma. Whoever did it, because I don't know your face, thank you so much. But we all know trauma is like a balloon. If you blow up a balloon, eventually that balloon will pop. Secondary trauma is air in a balloon. Trauma from a gunshot is air in a balloon. So what we've learned is that until you support folks who are experiencing trauma, the likelihood of violence will increase. I myself have seen people hurt and killed, and I have seen communities in Baltimore where young people step over a body, go back to their porch, and the next day they're playing in the street. and they themselves have not been provided services. That's secondary trauma, they take it to school. That's secondary trauma they give to each other and their family. So PAVE, Pathways to Advocacy Against Violence, is a part of our ecosystem. What we've learned is that we need to be able to provide support to help folks who've seen people get shot, folks in the hospital whose family members are experiencing the crisis of seeing their loved one out of bed, get the services that they need around trauma. So all these entry points, and sorry, because I could talk about this, I get pretty excited, so I will slow down. All of these opportunities around helping someone from a holistic approach is about an ecosystem. I see a hand. We'll get to your questions. So what I want you to understand, and I will close, what I really want you to understand from your place of existence in this fight against this disease is that policy change, I'm working with guys on the street and I'm helping them understand you are advocates for change, but until we address the immediate needs, but we have to help them understand policy change, advocacy, all of those things are parts of this ecosystem of supports that end the cycle or are a process that help to mitigate the spread of this disease. So if I could leave you with anything, I want you to understand this is a comprehensive, coordinated approach to end violence. Our hospital responder programs, our Safe Streets workers, the 58 guys that we have who the hospitals call and say, look, there's another violence that's about to happen because we got somebody here in this 72-hour window who wants to retaliate. How can you help us outside? How can we get PAVE in? So there's a coordinated effort that is happening here in Baltimore that is an opportunity for some real systemic change to address the disease of violence. I think I'm done.
Thank you.
Thank you so much, Ms. Jones. And thank you to all the panelists. Ms. Nathanson, did you want to add on?
I just wanted to say that that is the end of our formal presentation. I've got the chills over here, so I'm just going to go back on mute. Thank you.
Well, thank you so much. And thank you for jumping in when I forgot to unmute myself. I really want to thank all of the panelists because I think this was a great first briefing for this subcommittee because it identifies the comprehensive work that we do in this subcommittee, but also how meaningful the result can be. And with that, I want to open it up to questions. Delegate Rosenberg.
Thank you. Thank you, Madam Chair. Delegate Fisher, your clinical data made the case that prevention pays, that if we can intervene after the first incident, perhaps even intervene before, that we don't have a second incident and there are other beneficial effects. Can these services is there a need for more funding? I assume there is. And can that be funded with the federal dollars we've received, or it could be funded with state dollars alternatively or in addition?
It's a great question. Thank you. And I thank you for accidentally promoting me to a delegate. But so yes, funding.
Well, we once had a doctor, an emergency room doctor, who was also a delegate. So
yes. So yeah, funding has always it's been very up and down over the last 7 or 8 years or so. The Delegate Learman, now Comptroller Learman, created the State Violence Intervention and Prevention Fund, which there was funding initially, but it was pretty minimal after the first year. And that has made things a little bit challenging, right? Because as you might imagine, these are all team-based approaches, and the intervention is largely about people, connecting to other people. And if you don't have certainty over how many staff that you can have, it's hard to retain people. And if a program loses funding, then people go and get other jobs, and then you got to recruit again, and it's very, very difficult. As Tria mentioned, there's been some more federal resources recently with the Bipartisan Safer Communities Act. Last year, we're very thankful that you all in the legislature passed a bill that allows for Medicaid reimbursement for this work. The Department of Health is still working on developing rates and protocols and all of that with the target date of coming in July. So we do need an investment in this work to get on solid ground, right? It's been up and down, and every time a program has lost funding in the past, they're starting over again. They really are. So it's definitely an area that we'd love to work with you on.
Yeah.
Thank you.
Thank you, Delegate. Delegate Lopez.
Thank you, Subcommittee Chair Bagnall. I am new to HGO and new to this subcommittee. I was previously on judiciary, and I worked a lot on gun violence prevention. And so I have to tell you how hopeful my heart is after these presentations, because on judiciary, to use Freedom Jones's analogy, we're treating the disease and we're treating the ailment as opposed to really trying to prevent it happening. And that's clearly the work that you're doing here. So I'm very, very excited to be a partner with you and continue this work. I know, Ms. Jones, did you have a?
Yes. In treatment of a disease, one of the things I really am grateful for is that this is seen as a disease, because traditionally there's blame, and if we can remove the blame, we can treat the violence as a disease and get the needed supports and services. We don't blame people who have cancer. You understand? And so, there's a history of reasoning. We can dissect why. That is not the issue. The issue is supports and treatment. So thank you for saying that.
Sure, absolutely. I believe it too. So that makes it even easier to say. I represent a district in the northern part of Montgomery County in Germantown, and Germantown has a lot of gun violence, usually related to drug trafficking, lots of youth violence. And so I'm wondering, when you talk about community violence intervention, a lot of times the state conversation is centered around Baltimore City and centered around Prince George's. But I'm wondering if you could explain to the subcommittee a little bit more, provide some details about how these community violence intervention programs work in communities across the state. It's not just concentrated in those more urban areas.
I mean, I can attempt to address that. So I was actually speaking to some folks in the county this week because there are violence is like a disease. It's neighborhood to neighborhood and county to county, and they're looking at what they can do within their realm or scope of ability. And so there's a model, and that model about an ecosystem, about violence intervention responders can be tweaked based on your need, based on the area that you're using or living. And so their model exists, and partnership in the ecosystem means that we talk to our partners in the county and help them, build what they need to do based on where they are. And so my suggestion, and because I understand, that there's so much need. My suggestion is that look at the structure and the model, and then find out who can provide the services that are in that area, because we don't have to invent the model. And we're more than willing always to talk and to support, because that's what we do. And so that's what I offer. And because this is a movement that is happening across the country. There's a movement about an ecosystem. There's a movement about true partnership. There's a movement about public health as a theory to address violence.
Ms. Stanley, did you want to add on?
Yeah, if I could add on to that, just also to acknowledge, as a coalition, Marylanders to Prevent Gun Violence, we are focusing on the state of Maryland, not so much as just sectioning off into particular counties or cities. We want to make sure that violence prevention is affecting everywhere in Maryland as a state. So at any point in time, we would love to discuss with you possibly how we can connect with you more on what's going on in your county, how we can support you. As Kyle mentioned, we are looking for a funded increase for $40 million violence intervention and prevention bill, and that will be for the whole state of Maryland that we're looking to support with that. So we would love to connect with you more about what's going on.
Thank you very much, Ms. Stanley. And for the benefit of the subcommittee, I know in our hearings and we normally have one question, one answer from the panel. With our briefings, we give more latitude because this is an issue we need to understand and be able to sort of wrap our heads around. The one question, one answer rule does have some latitude when we're in briefings. Delegate White.
Yes, thank you so much. And thank you again to our panelists. This was such a insightful conversation. I would like to hear a little bit more about the average amount of time or that people within these community violence intervention programs, how long do they stay? How long are they followed? And how long are the wraparound support services provided for them within the program? Thank you.
Well, I can take that if you like. So one of the things that we have not done as well as we would like is to support the responder. The responders are coming to this work with their own trauma. So there has been some turnover because we have not put our hands around them to strengthen their ability. And we're going to do better with that. I think in the effort to bring more sites to the hospital structure, the ability to provide more supports is what the intention should be to the worker. Okay, so each program, for example, a Safe Streets staff can meet with a high-risk participant, and there's a criteria for high risk, can work with that person for as long as it takes, can wake them out of bed, can go with them wherever they need to go, can do what's necessary. And then there's about the ecosystem. Because we want to give a warm handoff to ROCA, because we want to connect folks who are experts in their service area, and then through that coordinated effort, keep a conversation about best practices and support. That can be anywhere. There's no time constraints for the length of time. It's because we don't know when people get it. We don't know. It's about people often take 2 steps up and 2 steps back. And so it's about supporting them. Traditionally at the hospital, it's anywhere from 6 months to a year's time. And that is done because it's not about the hospital. It's about the hospital turning them over to the ecosystem in that warm handoff. And that's about a comprehensive approach with a strategy to provide the supports. Now we're finding that there's a little bit more to it because we're seeing that some of those injuries at a hospital are more severe and require a longer time of support. Say someone who becomes a quadra or paraplegic. But there is a bit of a formula. So hospitals are traditionally 6 months to a year. Safe Streets can be ongoing, and there are programs in our mental health could be ongoing. It could be the family PAVE is the same way. So it depends on the warm handoff or the support required, because what we don't want to do is drop folks and think that they're ready when they're not, because then we have the recidivism of violence that happens ongoing.
Thank you very much. Dr. Fisher, I saw you unmute. Did you want to add anything from the hospital perspective or the?
Freedom answered it perfectly. I can move on to Delegate Hill. I see she's got.
All right, thank you very much. Delegate Hill.
Thank you very much, Madam Chair, and thank you all first of all, for the work that you're doing and for the presentation. So I'm just trying to get a grasp around this whole piece, right? So it sounds as if you are all doing important work, but not necessarily coordinated and overlapping. And I guess I'll direct it to you, Martha. What is the holistic goal and what are you all asking for? So last year we passed Delegate Smith's bill that talked about violence prevention programming, you put some money into it, some other resources. We did not pass Delegate Lehman's bill that would have created grief counseling services for family survivors of people murdered by gunshot injury, which is also an important piece. So there are lots of good things going on. We see it in different jurisdictions. There's also within the community a sense of frustration because people feel like the outcomes aren't there. Dr. Fisher, your slides, you talked about a University of Maryland study that talked about over 5,500 folks, I guess, in a year presenting who are Medicaid recipients who presented with gunshot injuries. But you didn't tell me about the non-Medicaid recipients who showed up. And the studies that you showed talked about 50 people in a study, case control, and 50 people studied and 50 people. So we're talking about 100 people studied out of 6,000 folks, right? So I'm missing the piece that you're bringing to us that says this is how we put all these pieces together. So, and if I may, I hate to give this long introduction, but it's just really hard for me to wrap around. So if this were cancer, if this were breast cancer, right? We'd have a breast cancer center where the radiologist, oncologist, the oncologist, the plastic surgeon, prime cares, they would all be there. We'd have support groups. We'd have support groups for the family. We would follow these people out for a long time. We'd have real data about the changes that we're making in their lives. What is the equivalent thing that you would be coming to us and asking us to do? Are we talking about some umbrella program, or we're just talking about continuing to ad hoc support every sort of idea that comes up that holds some promise?
Okay, Delegate Hill, thank you for that question. I'll take it first and then turn over to my colleagues to get more specific. Clearly, the funding side is very important. We're not coming to you with that because you're not the budget committee, but the dollars for violence intervention, for predictability, for staffing, for continuing, as was asked before, about how long people stay in the system. What we're asking, we as a group of advocates and service providers strive always to be more interconnected and coordinated. The organizations you see here are very enmeshed with each other. So we are coming with the same priorities. What I think we're asking you to do is to use community violence and violence in general and the connection between the impact of violence on healthcare outcomes, to use that as an additional filter when you're looking at proposals over the next year, over the next 4 years. Remember to think, is violence that people are experiencing, is that impacting their outcome in this particular bill that we're looking at, for example, maybe about outcomes around cancer treatment. So if patients are receiving cancer treatment, but their community violence levels are so high that they aren't able to come for their cancer treatments, how are those experiences and that environment impacting their health outcomes generally? That's the connection we wanted to make today, not so much an ask for a certain level of funding. Clearly, we're doing that in the other committees, and to the extent that you can support that by characterizing for them that this helps save dollars in healthcare. So it's not just funding this one violence program, but it's saving money in the healthcare system overall and making those connections by using that as a filter. So we don't have a specific ask for a program, an umbrella program or a coordinated program. We are attempting to do that in the field in real time. It's when you're looking at policies that we want you to remember that this is something that, as we heard in 2015 from our community health needs assessment, this is the healthcare issue that I worry about, is violence from our communities. Does any of the other panelists want to get more specific on that?
Yeah, I would love to add to this. Dylan, that's such a good question. And I think I can feel the frustration, right? And I think we all feel it, right? Where it's like, well, didn't we pass this bill to try this last year? And a couple of years ago, I remember this, and I've heard about this. But on the ground, when we've been working throughout the state in it, to use your analogy, right? So for good cancer care, you need lots of things. You need a surgeon, you need radiation oncology, you need diagnostic radiation, you need pharmacy. And because the funding has been up and down, it's not that we've ever built a cancer center and had everything going all at once for the last 10 years. We tried hiring the surgeon one year, but there was no, radiation oncologist. And maybe another year we had our plastic surgeon, and all the pieces weren't there all together to really get the system up and running. And Freedom has been, using the word ecosystem a lot, and it's a word that we think is really important in violence prevention, because what we know is that people in the community that are at risk of being violently injured or violently injuring other people, they're at different places in their entire life, right? So at one point, someone might be in the community. At some point, they might be with us in the health system. At another point, they may be associated with the justice system. And so any one of these strategies, they're more likely to connect people at individual times, right? And that's why we really need certainty for multiple approaches to build this ecosystem, so that no matter where someone is, if they're at risk of violence, we've got a person that is connected to them, and then we can get to the point where we can start working together as a system. Because it has been, like you mentioned, we tried street outreach here, but then the next year there was hospital-based programs, and it's been so up and down that that coordination just hasn't been able to happen yet.
So Madam Chair, if I may, Dr. Fisher, so is, aside from the funding which is going to the committees, is that something that it would be helpful for this committee to take on as a task, that maybe we are talking about, a true Maryland Center for Violence, which is not about people who perpetuate it, not just about people who are violated by it, but by people who are at risk and exposed to it in other ways. And it is a time for us as a state, just like we have a Department of Health and we have a Department of Environment, should we have a Department of Violence or a Division of Violence? I'm asking if is that something we should be putting serious thought into?
I think it is, and that's something we've, at the hobby, because we do national level work, there are a number of states that have state offices of violence prevention that are able to kind of look at all the different sectors and bring them together, whether or not it's the health sector, labor, justice, and make sure that they are connecting everything to have a unified response.
Yes.
So let's hear from, I feel like Freedom Jones had something to add, then we'll get to Delegate Riley's question, Delegate Bagnall's question, and Delegate Chisholm's question. And thank you, Delegate Bagnall, for holding down the fort. Freedom, did you have something you wanted to add?
Delegate Terry, if I could come through the Zoom and hug you, I would. I mean, there's Seattle, they're doing these things. And so it's really, like Kyle said, the coordinated effort at so many levels is what's necessary. So thank you. That's hopeful for me that you even brought that up.
Thank you. Delegate Riley.
Thank you, Madam Chair. I think Ms. Nathanson kind of answered the question, but it was kind of a comment that Lisa Jones had said, and I just wanted to clarify that. Are you saying that the shooter or the victim of a gunshot, did you say that you thought that that was a disease?
I'm saying that violence across the board is a disease. I'm saying that if we're looking at the person who's shooting, and we're not going to treat that person the same that we're treating the person who is the victim, we're missing an opportunity for healing and growth. Okay. What I'm saying is that violence, yes.
Yeah, but wouldn't you say more that was more of not the necessarily person at that time, whether the shooter or the victim, but more of what's going in the community environment, and just the idea that is out there that being involved in a crime or what have you is a good thing. We have to change that aspect. So is that part of this education package?
Changing the mindset of why a shooter wants to shoot, understanding the history, understanding the fullness of where that person got to that place is addressing the disease. So it's about delabeling and understanding that the victim, the perpetrator and the victim are a part of the disease. And so we are trying to help people by changing the norm, saying, this is not right. How do we fix whatever the issue is? And so sometimes we hear people saying, in this work where there's violence mitigation, why aren't you addressing, because the Safe Streets team is supposed to stop the shooting and killings. Why aren't you addressing the drugs? Why aren't you addressing this? Because if you're doing this work as a looking at cancer, and cancer is spreading, you don't just look at one part, you look at the fullness of it. And so what we're saying is that we're looking at this particular model to change what people think is good or what is not productive. And having someone shoot someone causes the disease to spread. Having someone who's receiving the bullet causes the disease to spread. And each should be addressed in the appropriate manner to help change the disease.
So it's a larger picture.
It's a big picture.
Thank you very much. Thank you, Madam Chair.
Thank you, Delegate Bagnall.
Thank you, Madam Chair. And this is kind of a follow-on to Delegate Hill's question. But when we're talking about, establishing these resources in the communities at need, do we have a way to identify where these resources are needed so we can be more proactive than reactive? Do we have that data, or do we need a methodology to collect that data to identify where we can be setting up these resources?
Absolutely. This model is data driven. All of this is about, because we don't set up areas for mediation unless the data says it's warranted. All of this is evidence driven. So there's a lot of data being collected. There are lots of studies. We're looking at collecting data to see the long-term effect better. And that is some of the work that we're trying to do as this coordinated effort. And so all of it is evidence driven. So we're collecting data in the hospital. We're collecting data on the streets. We're collecting data to see how this model or what should be addressed, because and that's what we have to do to move the work. It's all about the data.
And Madam Chair, will we get that report? The committee?
I can make sure that happens. Yeah.
Thank you so much.
Absolutely. Delegate Chisholm.
Thank you, Madam Chair. I hate to take a very complex issue and try to simplify, but essentially it's preventative care. And when we were talking about that, my wife's an occupational therapist in the Prince George's County school system, and we talk often about this, and she's a firm believer in the ACEs program, and I remember when ACEs went through and we looked at it, I just don't recall if we put any funding mechanisms into any of those programs. And more importantly, do you guys intersect with any of the ACEs programs? Because obviously the earlier you can put preventative care into place, hopefully we can stop the shootings and all the violence where we're seeing it throughout Maryland to begin with.
We do use ACEs at the Center for Hope, but ACEs requires a skilled person to deliver that kind of assessment. We have a whole mental health component that does assess by using ACEs. There's also, we're looking at studying the science of hope so that we're able to integrate certain measurement tools. So you're spot on. There are tools like ACEs that are being utilized. And how does what we find with the ACEs component integrate in our work? And so that is what we're doing through our mini ecosystem at the Center for Hope. We're looking at the findings that we find from ACEs and how does it affect the folks who are not taking ACEs. So yes, you are spot on with what you're saying. It is happening in lots of places. I know it is happening with us at the Center for Hope. I wish I could speak more about that particular evaluation, but if you need some more, maybe I could get something from you by one of my colleagues at the Center for Hope.
Okay, thank you. Thank you, Madam Chair.
Absolutely. Final question from Delegate Hutchinson.
Thank you, Madam Chair, and to all the presenters today. That was just unbelievable, particularly when you look at the cost of all of this, which is something that sometimes people don't really understand. And my math here says that it's about $800,000 for every gun murder in Maryland, which is just astronomical. I need a point of clarification. It may be Ms. Nathanson or Ms. Stanley. I think it was on page 4 of your slide. You had indicated that gun violence is costing the state of Maryland $5.7 billion, but $375 million of that is paid by the taxpayers. So there's a gap there of about $5.3 billion. Who's paying that?
That's actually a good question. Thanks for asking. So from my understanding, and maybe Kyle may have or Martha may have more of an understanding on this. From what I know, maybe Medicaid coming into play, maybe some government funding. Kyle, you may be able to step in a little bit more, but I believe most of that may come from government funding or like insurance cost of where that is coming from. Kyle, if you have anything to add, please feel free.
So one of the troubles with looking at costs of gun violence is it gets really complicated, and some of the money is, invisible, right? So there are the direct costs that are easy to measure, right? It's things we talked about like medical care, costs of investigation by police, court costs, jail time for folks that are convicted. But then there are some of the harder to see costs. And that's where, when you see the higher numbers, they're accounting for the things that don't jump out at you. So for example, if you have a 25-year-old man and he gets shot and he gets a traumatic brain injury and can't work for the rest of his life, what are the lost productivity and lost wages for that person? Or let's say there's an area or a neighborhood with high violent crime, right? We know that if you look at that neighborhood, businesses do not move into that neighborhood. They leave. And so you have lost tax wages from that neighborhood because economic activity isn't there. You don't get wages from people working there and lost productivity. And then you can see how this just has this ripple effect of some things that are very obvious and some things that are less obvious. And that's where the higher numbers end up coming.
Thank you.
Thank you for that. I don't see any more questions from members, but I just want to thank everybody for the robust and really interesting conversation. And we will obviously continue this dialogue throughout the session. Thank you all for these great presentations. Want to remind the members that in general, bills that come before the Public Health Subcommittee are going to be heard on Tuesdays, although sometimes they're heard on Thursdays. This week, we have the Public Health Commission that is being heard on Thursday, so pay attention to that because that will be coming to our subcommittee. Anything else of note, Erin, I should bring up for subcommittee members?
No, I don't think so. Just, pay attention to that bill hearing because it'll probably be in subcommittee this time next week.
And we will see you this time next week at right after floor session or 11 o'clock, whichever comes later next week for the Public Health and Minority Health Disparities Subcommittee. Thank you, everyone.